morning, Mr. and Madam Chairman. Good morning, ladies and gentlemen, friends, colleagues. And thank you for inviting me to speak on imaging biomarkers and disease prediction. I think this is quite an important topic. We're trying to refine our ability to predict both disease as well as disease response to treatment. These are my financial disclosures. The past 2 days we've been talking about multimodal imaging, and that's really an important concept in ophthalmology, certainly in medical retina. We can't do without multimodal imaging. There will be other talks later talking about how we can be selective in choosing the modalities of treatment. But this is the traditional list of imaging modalities, right? It's a whole long list, but as Wei Kiong said yesterday, it's not a buffet syndrome. We have to be very specific, right? So if you like shellfish, you go for the shellfish counter. If you like beef, you go to the beef counter. I'm just going to have time to cover two things: optical coherence tomography, OCT, and fundus autofluorescence. Right? The rest of it, I think, depending on the disease pathology or presentation, we'll have to be selective. But let's talk about OCT first and foremost, because I think it's the most widely used modality in clinical practice today. There are quantitative as well as qualitative markers of OCT. Quantitative, we all know, right? We use that in our trials and our clinics: central subfield thickness, cube average, macular volume. In fact, cube average is becoming the number one modality, endpoint in some of our clinical trials, because it gives you a better representation of what's happening in the entire macula, not just at the fovea. But really, it's the qualitative changes in OCT that determine what you can detect in high detail. It can be fluid, hyperreflective foci, and so on. And I'll go through some of these. Firstly, quantitative. Historically, especially with the Sritatath time domain OCT, it gave us a snapshot of what was going on in the macula, whether it's macular thickening or edema. And the response, if you recall, in some of the early trials were 50 micron or 100 micron changes. If you think about it, nowadays we are looking at 10 micron, 20 micron changes. So 50 and 100 micron changes were really quite gross. But you can't, I guess, blame that because of the pixelation. In truth, quantitative changes in OCT thickness correlate poorly with visual acuity outcome. So you can't say if you've got a thick retina on the OCT, you're going to have poor vision. Not always. So people have moved away from quantitative towards qualitative assessment of OCT. Why? Because with our moving away from time domain to spectral domain and now with SEPSOS, we have much greater detail and resolution to be able to differentiate the changes in the various compartments of the macula. Typically, say in neovascular AMD, we're looking at fluid in the subretinal space, intraretinal space, and the sub-RPE space. This is very important. In the past, we did not have a good appreciation of the various compartments of fluid. Why is this important? Because the fluid in each compartment has different consequences and implications on vision. Intraretinal fluid is by far the most dangerous, and it is something that we don't tolerate at all, right? It is an important predictor for vision. Up to 60% of patients with treatment-naive eyes have intraretinal fluid, and the main pathologies associated with intraretinal fluid are not just classic CNV, but RAP. So if you see intraretinal fluid, especially with hemorrhage, then you think a little bit about retinal angiomatous proliferation, or otherwise known as type 3 choroidal neovascularization. And it's a sign of a more aggressive lesion and late presentation. We learned a lot from trials such as CAT, because we could tell over a period of time what each of these compartments of fluid would do to final visual acuity. After all, this is our goal. We want to be able to treat these compartments as well as we can. So very clearly in B, you see that intraretinal fluid consistently results in poorer outcomes, right? If you don't treat intraretinal fluid, you will always end up with poorer visual outcome. And that's not so with subretinal fluid at the bottom or sub-RPE fluid. The vision can be quite neutral, even if you have some subretinal fluid or sub-RPE fluid. And in this study with monthly ranibizumab, refractory fluid sometimes exists. We have maybe 20-30% of our patients at 1 year still with persistent fluid. But it is the intraretinal fluid that causes the most damage. So long and short of it is, don't leave intraretinal fluid. Be as aggressive as you can. In fact, if you see intraretinal fluid, I don't extend. You can maintain sometimes, or you reduce intervals of treatment. When you have two are worse than one. Intraretinal fluid together with pigment epithelial detachment, that's really bad news. Right? And in which condition do we see this? RAP. All right? So RAP is an interesting situation. In Asia, we don't see that much RAP all the time. But if you don't treat RAP aggressively, they will end up with geographic atrophy. Subretinal fluid is a bit controversial, right? All of us see subretinal fluid. How we manage subretinal fluid is quite subjective. There are two camps. One camp says we can tolerate some fluid, for example, up to 200 microns. Another camp says, no, you should not. Treat it like any other form of disease activity. I'm in the latter. I want to treat as much subretinal fluid as possible. But sometimes, when you reach a plateau and you can't achieve complete drying of the subretinal fluid compartment, then I try and maintain and extend intervals. But I will not allow subretinal fluid to increase. In other words, while you can tolerate some subretinal fluid, you must continue them on treatment. And that is the fallacy. A lot of people stop treatment. They say, well, I can't get rid of subretinal fluid, I'm going to stop treatment. But that's wrong. It only can be tolerated if you are on a treat and extend basis. You are still applying some kind of suppression of disease. And the role of subretinal fluid is really interesting. This study, for example, shows that when you have subretinal fluid, and whether you treat aggressively or don't treat aggressively, the visual acuity remains about the same. Okay? So subretinal fluid is a real conundrum. For a while, people were talking about the role of subretinal fluid in protection against geographic atrophy. I think that's been more or less debunked, because if you look at all the trials in general, having subretinal fluid does not prevent geographic atrophy, and you can have geographic atrophy even in the presence of subretinal fluid. I move on now to hyperreflective foci. These are little bright dots that are found on the OCT. And it was Gabriel Koskas from France that really proposed the theory of activated microglial cells. There are other possibilities like RPE cells, macrophages, and so on. But I think most authorities now accept that they are a form of activated microglia. They reflect some kind of underlying inflammation. And we see this particularly in patients who are not so responsive to anti-VEGF. And when you apply some kind of steroid therapy, especially in diabetics, they tend to respond. It may be an early sign of RAP again in neovascular AMD, and they are associated with poorer visual outcomes. These are some examples of hyperreflective dots, and you can track these using AI now to see how effective or ineffective your treatment is. Another marker of poor prognosis is outer retinal tubulation. They are often misdiagnosed as intraretinal cysts. The difference is with outer retinal tubulation, there's a wall. It's like a cyst, but with a wall. And that wall tells us that these are almost like rosettes of tubular structures that are usually from chronic disease. They're associated with a poorer baseline vision and less visual gains even with treatment. And when we see ORTs, very often we are less aggressive already because we know that the prognosis is poor. This is really an important topic. Subretinal hyperreflective material, I feel not enough attention has been paid. What is this? It is a hyperreflective mass between the neurosensory layers and the RPE. Often easily missed. If you go with just quantitative assessment, you will not pick it up. And if you don't go through every line of raster in the macular cube, you will miss it. Why is this important? CAT showed that up to 80% had shroom at enrollment, decreased to 50% after you treat. They are related to activity, so disease activity, and there is a correlation between thickness of shroom and VA. So I do not leave shroom, right? If I see shroom, I will treat aggressively. They are predictive of non-responders, and the main problem is scarring because it's fibrinous material, so there is a high risk of fibrous scarring over time. This is shroom in a higher magnification. This is particularly important in AMD and myopic CNV. Remember, myopic CNV don't present typically like neovascular AMD with fluid. They start off with shroom and then later end up with a fossa fugue or scar. Interesting point about choroidal thickness. Very often we don't pay too much attention to the choroid, except if you suspect maybe polypoidal or pachychoroid disease. Choroidal thickness we know will change with age, so there's a variability. But AMD patients generally have thinner choroids. This is a useful differentiating marker between PCV and typical CNV. So you have your patient with typical CNV and you see thick choroid, then perhaps this patient has pachychoroid neovasculopathy, and they respond differently to treatment. For example, they may not respond to anti-VEGF so well. You would have to add combination therapy with photodynamic therapy. In general, PCV patients have thicker choroids and they're associated with a better visual prognosis, and maybe this is a sign of a protective effect on the choriocapillaris. So we see generally that if you've got a thin choroid, you would tend to treat with anti-VEGF rather than PDT, and be very careful when you apply repeated PDT on patients already with a thin choroid. Vitreomacular interface is another neglected area. We treat with injections all the time, right, in our clinics. But the role of the vitreomacular interface is actually very important, right? There are many studies now that show that patients with vitreomacular adhesion, persistent adhesions between the vitreous and the macula, do badly, right, with less frequent injections. In other words, you need to be able to maintain control of disease. If you have a PVD at baseline, they have a more likely a benign cause. Post-vitrectomized eyes, and this is of practical importance in diabetics, they have faster drug clearance. I know that some trials in these DRCR-NET show no difference, but clinically I see a difference. A patient who would otherwise have been able to be on a 6 or 8 weekly interval might need 4 or sometimes even less 3 weekly treatments. Finally, I want to end with the OCT bands. I think we're all familiar with looking at high resolution OCT, but the outer bands are really important because this is where the photoreceptor integrity is. External limiting membrane, ISOS junction, the outer segment RPE interdigitation, and the RPE Brooks membrane. If you have any kind of disruption to the outer retinal bands, this is bad news for visual acuity because we know there's a disruption. It's an interesting analogy I read a long time ago about how you have a marching band and you see all the belts lined up in a row. And when one of those band members has fainted, there is a disruption of the band. And this is exactly what we are seeing on the OCT. It doesn't mean that the OCT shows conclusively that the band is lost. It's just that the alignment is gone and you don't see the same stacking of the layers of the macula. So when you see an outer retinal band disruption, we know that the prognosis is less good, and this is something that generally I would advise patients. The patterns of ellipsoid zone changes that we described are linear or complete, that's normal. They can be broken, they can be deformed, thickened, or absent. This is an example of a broken and disrupted outer band, especially in the ellipsoid zone. When we treat these patients on, say, an anti-VEGF therapy, and there is a restoration or a gradual reduction in the extent of disruption, this is also a good prognostic sign. So I can show patients that while their vision is not good, for example, after treating, they're still counting fingers, but when we see a gradual restoration of the ELM as well as the ellipsoid, then there is a little bit of hope for them. And it gives them an appreciation that this process is going to take time. Very often patients are very impatient. They want to be able to see an immediate wow effect after you treat, and that's not always the case. That's outer retinal bands. The inner retinal bands are probably more significant for diabetic retinopathy or the retinal vascular diseases. And we talked about hyperreflective foci earlier. That is a sign of inflammation, activated microglia. There is therefore a greater place for the use of steroid treatments for patients with more hyperreflective foci. But I want to touch a little bit about DRIL, this organization of the retinal inner layers. We know that in certain studies like Yosemite and Rhine, this is faricimab for DME, HRF, hyperreflective volumes, were associated with severity of disease. Right? So the more HRF you have, the probably more chronic and the worse the disease. And when we start treating, we find that faricimab was superior to aflibercept in reducing these HRF volumes. For DRIL, it's slightly different. It's about visual prognosis and recovery. So on the left, you see a patient with DRIL, so disrupted inner layers. You see that the inner layers stop just about the fovea. And anything within that 1 millimeter of fovea, when you see DRIL, that's also a sign of poor recovery. So there is a good correlation between central subfield thickness and DRIL length. with visual acuity change. In other words, once you see you drill within the first 1 mm at the fovea, the visual prognosis is guarded. And then finally, fundus autofluorescence as a biomarker, both for diagnosis as well as for prognosis. Let's talk about macular telangiectasia very quickly. Very often missed in the early stages before the cystic lacunae appear. And in fact, the clue is in the autofluorescence. There is a loss of hypoautofluorescence at the macula. And that's because of loss of luteal pigment, which is as a blocking effect on FAF. So this is a very helpful tool when you're looking at a fellow eye, perhaps. You see one eye with atrophy, and you're not sure what the disease is. Look at the other eye with fundus autofluorescence. Another masquerade for neovascular AMD is vitelliform. And this material doesn't disappear when you give repeated intravitreal injections. In fact, visual acuity remains about the same. And yesterday we heard from Seung about geographic atrophy. So fundus autofluorescence is really an important tool in AMD, particularly the junctional zone. Right? So when you have a junctional zone, such as diffuse trickling, this has been associated with fast progression. And when you have a fast progressor, these are patients you need to treat them early as much as you can with the complement inhibitors. This is how we then are more selective in choosing the right treatment. So the diffuse trickling, the diffuse types of junctional hyperautofluorescence are important. And finally, in retinitis pigmentosa, rod cone dystrophy, some patients demonstrate this hyperautofluorescent ring. It is described by Robson and Holder. And what's significant about this ring is it tells us the leading edge of the disease. Anything within the ring is more or less normal, on the ring reduced, and outside the ring, no vision or no visual sensitivity. So when we see this ring changing in diameter as it constricts towards the fovea, this tells us that disease is progressing. And we can chart the rate of progression just as we do in glaucoma. And these are patients often have underlying problems, either from the primary disease or even secondary autoimmune retinopathy. So I've tried to go through as much as I can some of the more significant biomarkers. We are very lucky that we have so many modalities at our fingertips. The key here is to learn which ones to use when. Thank you very much.
So among the biomarkers, which one is your priority?
I think most of the time OCT is the first one that I look at. After all, it's the most commonly used modality. So with the OCT, if it's neovascular AMD, I'm looking at fluid papa. If it's DME, I'm looking for things like hyperreflective foci and drill, because these tell me what to look out for if they don't respond to anti-VEGF.
When you see the hyperreflective foci in DME patient, do you start with the only anti-VEGF only, or you consider the first the combined with steroid treatment?
There's generally no need to use two different mechanisms of treatment. So I will start with anti-VEGF. And we know that even with anti-VEGF, hyperreflective foci can respond, can reduce. It is only when the hyperreflective foci don't reduce with anti-VEGF and the fluid still remains, then that tells you that maybe there is a different driver to the disease, such as inflammation. I generally don't start with steroid.
Thank you very much.
Thank you.
Good morning to everyone, and thank you to Zeiss for the invitation to speak. Today I'll be sharing on some of the newer therapeutics that is already on the market and are upcoming. These are my disclosures. So retinal practice today presents us with many different challenges. And this is a summary of the different important recent FDA approvals. And I shall be going through some of the top-line results of these products. And to address these challenges, we now have next-generation anti-VEGF agents that provide us with multiple therapeutic targets and have got longer durability of action. We also have got new drug delivery methods, and novel therapeutic indications have also emerged. Sorry, I think this is the wrong set of slide. I'm sorry. Is there a different set? The cell site is not updated, I think. They uploaded the wrong one. Okay. Sorry, I think they uploaded an earlier set of slides, but I guess it's fine. I'll just carry on with what I have over here. Yeah, so faricimab is one of the next generation anti-VEGF agent, and it has a dual pathway inhibition, inhibiting both the VEGF pathway as well as the Ang2 pathways. With the dual pathway inhibition, we are able to target the multiple different pathophysiologic disease driving mechanisms, including neovascularization, leakage, inflammation, as well as fibrosis. Tenai and Lucen study recruited patients with wet AMD, and Yosemite and Rhine recruited patients with DME. In both of these studies, the treatment comparators were aflibercept 2 milligrams. The only difference is that in the Tenai and Lucen study, 3 loading doses of aflibercept 2 milligrams were given, while in the Yosemite and Rhine, there were 5 loading doses of aflibercept 2 milligrams as per label indications. The treatment arms that were being investigated in both of these studies involve faricimab in Tenai and Lucen up to Q16 weeks dosing interval. And in Yosemite and Rhine, similarly, there were 2 faricimab arms. One was up to Q16 weeks dosing interval, and the other was Q8 weeks after 6 loading doses. In the faricimab 6 milligram arms of both studies, the arm that was up to Q16 weeks, patients could have their dosing interval either extended or shortened based on pre-specified criteria. The primary endpoint of all of these trials were non-inferiority, comparing between the faricimab arms and Eylea or aflibercept 2 milligrams, which was achieved in all of these trials. And in terms of durability, we can see that in the Tenai and Lucen study, patients who were on faricimab, 80% of them achieved a dosing interval of 12 weeks or longer, with more than 60% achieving a dosing interval of 16 weeks. And in the DME trials, faricimab performed as well in terms of durability, with 78% of them achieving a dosing interval of 12 weeks or longer, and 62% achieving a dosing interval of 16 weeks. We cannot talk about neovascular AMD in Asia without giving some thoughts to PCV. And that is why the Selwyn study was conducted. It was open-label, single-arm monotherapy of PCV patients using faricimab. And the 16-week results after 4 initial doses of faricimab has been reported, with an 8-letter gain in vision at week 16, accompanied by a decrease in central subfield thickness of around 150 microns. 8 in 10 patients achieved polyp inactivation, defined as the lack of fluid on OCT despite an open polyp, and around half of the patients had complete polyp closure. Aflibercept, on the other hand, is also another next generation anti-VEGF agent, the 8 milligram dose of aflibercept. The aflibercept molecules have got several properties that support the sustained disease duration of action. Firstly, it has the highest reported potency. It also has got the highest binding affinity, and it works on multiple targets, including VEGF-A, VEGF-B, and placental growth factors. It was also found that there was a 34% unexpected but beneficial slower ocular clearance with the 8 milligram dosing compared to the 2 milligram dosing. And together with the increased molar dose, These properties of the aflibercept molecule help with sustained VEGF suppression, and this drives the data we see in the clinical trials. In PULSAR and PHOTON, which are a pair of registration trials for aflibercept 8 milligrams in AMD and DME. Again, these two trials were similarly designed, with aflibercept 8 milligrams being in 2 treatment arms. The first one would be 8 milligrams aflibercept, 12 weekly dosing, and also 16 weekly dosing after 3 loading injections, compared to aflibercept 2 milligrams Q8 weeks after 3 loading doses. In the PHOTON trial for DME, the only difference is that the comparator arm, aflibercept 2 milligram, had 5 loading injections as per label, compared to 3 loading injections in PULSAR. So again, these two registration trials, the primary endpoint is that of non-inferiority between the 8 milligram dosing and 2 milligram dosing, and that was achieved in both vision as well as anatomical change on OCT. There was also very significant durability outcomes from the PULSAR as well as the PHOTON trial. In the 8 milligram arms, again, the patients were able to have their dosing interval either extended or reduced in the second year based on pre-specified treatment criteria. And in this case, they were able to extend up to a maximum of 24 weeks or around 6 months. So in PULSAR, we can see that in the patients who were randomized to the 8 milligram Q16 week arm, they had 8 in 10 were able to achieve a dosing interval of 16 weeks or longer, while more than half had a dosing interval of 20 weeks or longer. And in PHOTON, a similar story is painted, with 9 in 10 patients achieving a dosing interval of 16 weeks or longer, and around half had a dosing interval of 20 weeks or longer. So we can see that, in summary, all the second generation or next generation anti-VEGF agents do give us much longer durability compared to what we had previously. Again, it's incomplete to talk about neovascular AMD without PCV. In PULSAR, although it was a study that is recruiting wet AMD patients, in some of the Asian centers, ICG angiography was performed. And looking at the ICG angiography allowed us some information on treatment of PCV using the 8 milligrams aflibercept dosing. 139 patients in the trial were diagnosed with PCV. And if we looked at this subgroup, we can see that there was around an 8 letter gain in vision, very similar to what we saw in the Salwin study. And this is also accompanied with a significant decrease in central subfield thickness of around 150 microns. And again, if we look at the polyp inactivation rate, around 80% had polyp inactivation and half had complete polyp closure. Let's change track and talk about port delivery system. Port delivery system is a specialized ocular device that is surgically implanted, and it holds a reservoir of ranibizumab molecules for sustained delivery. The on-label refill occurs every 24 weeks and can be done as an office procedure. Archway and Pagoda trials for the port delivery system recruited patients with wet AMD and DME. And again, the primary endpoint of non-inferiority, comparing between the PDS arm in both trials with monthly ranibizumab, was met in both vision and anatomy. The complications of infective endophthalmitis as well as conjunctival-related SAEs were more common in the PDS arm compared to monthly ranibizumab. And since the next generation anti-VEGF agents are able to give us a long durability of 16 weeks or longer, I believe the port delivery system in its current iteration for widespread implementation would be challenging. However, this still proves to be a groundbreaking proof of concept because the device may have potential to be used with longer acting agents or even novel therapeutic agents. Surgical technique improvements have also reduced the rates of conjunctival-related complications, and this may be a good option for certain groups of patients. Revakinagene tarotaxel has revolutionized the treatment of macular telangiectasia. It's currently the only therapeutic that's approved for MacTel by the FDA, and it has a novel drug delivery strategy. It consists of an encapsulated cell implantation of genetically modified RPE cells that can continuously produce CNTF to promote the survival of photoreceptors. A pair of registration trial for revakinagene reported that there was a 55% and 30% slower rate of photoreceptor loss when compared to sham. Although there was structural preservation, functional preservation in terms of measurements on the microperimetry were not consistently reported. The revakinagene is implanted as a surgical procedure. Therefore, the serious adverse events are as expected. However, for widespread adoption, I think a few questions remain. For example, how long can the implant last? An ARVO abstract did report that the CNTF from revakinagene can last for as long as 5 years or more, producing the CNTF required for photoreceptor preservation. Geographic atrophy is another field that has very much recent developments and is of great interest recently because of the new therapeutics that we have. Complement pathways have been implicated in GA pathogenesis, and we now have both a C3 inhibitor, pegcetacoplan, as well as a C5 inhibitor, varsicaptad pegol, that's available for use in the US. OAKS and Derby look at pegcetacoplan monthly and every other month compared to sham, and found that there was a 21% and 17% reduction in the treatment arms compared to sham. And more importantly is that in post hoc analysis, there are suggestions that the treatment effects of geographic atrophy seems to intensify over time as we see the divergence of the treatment lines compared to the sham lines. Gather 1 and Gather 2 look at the varsicaptad pegol monthly and found that there was a 35 and 18% reduction compared to sham in the reduction in the areas of GA lesions. And again, in Gather 2, where there was result from the second year, we also see an increasing effect of treatment compared to sham. The development of neovascular AMD with GA treatment remains of concern, and because the clinical trials were unable to show meaningful visual or functional benefits with treatment, the widespread adoption of GA treatment as well as regulatory approvals have been slowed. Moreover, we just did a webinar in Singapore and we discussed about GA characteristics of GA Asians, and we also found that most of the data from Asia suggests that being Asian, especially East Asian, seem to have a protective effect in both the incidence as well as the progression of GA, and overall we do seem to have a slower rate of progression compared to the Caucasian population. However, I think in the GA research in Asia is still lacking, and I think we need more data to allow us better information to make a better clinical decision. So I'll just move on quickly to some of the developing therapeutics. OPT-302, it's a first-in-class biologic to inhibit both VEGF-C and VEGF-D. It was initially designed as an adjunct for traditional anti-VEGF agents to intensify the treatment effects, but the trials have failed to meet the primary endpoints. Gene therapy for X-linked RP, botaretigene, this is product of J&J. It has also failed to improve vision-guided mobility in patients with X-linked RP. Gene therapy for neovascular AMD is coming. RGX-314 is designed as a gene therapy for wet AMD and potentially can be a one-time use kind of a therapeutic. And optogenetics is also a very interesting field. It uses gene therapy to introduce opsins into cells in the retina other than photoreceptors to enable them to see light. And finally, tyrosine kinase inhibitors is another set of therapeutics that has a potential because what it does is it inhibits the downstream or post-receptor signaling pathways of VEGF receptors, of Tie2 receptors, and this may have potential use in AMD as well as DME. So I think the continual exploration of new frontiers in retinal therapy is that's aided with advancements in science and technology, is bringing us closer towards bridging the challenges as well as the unmet needs in retinal therapy. With that, thank you for your kind attention.
You discussed about the current treatment and the future treatment. So what's going on with these future treatments in your clinic?
So I think we are in one of the larger institutions in Singapore. So we have been very lucky to be able to participate in a lot of these phase 3 clinical trials. Recently, we have started to be approached by some of these companies and institutions to discuss about the possibility of starting gene therapy treatment trial, both in the field of inherited retinal disease as well as in wet AMD. I think that's a very interesting and a very forward-looking kind of a partnership and opportunity, which I think we will definitely participate in if it does come into Singapore.
I have one question. Thank you for the good review. So you have a lot of PCV case and the non-durability available right now. So do you have any preferred drug on the PCV case? Or any specific reason?
All right, so I think the treatment of PCV has really evolved through the years. We were one of the reading centers for the Everest-2 study. So initially, my center was very big on combination therapy. But with the next generation anti-VEGF agents, and we can see from the clinical trial results, both Selwyn study as well as the PCV subgroup from Pulsar studies, I think more and more people are moving towards monotherapy of PCV. And using either of these agents, I think, give us very good initial treatment results for PCV. We can see that in both of these trials, we are getting a polyp inactivation of around 80%, as well as a polyp closure of around 50%. I think these are encouraging results, and monotherapy using either of these agents will be a good option.
Thank you.
Thank you very much.
Good morning, and I'd like to thank Zeiss for the opportunity to present at this meeting. These are my disclosures, and I do consult for Zeiss. So we'll be talking about practical pearls in retinal image interpretation. And this is a very important topic because with the aging population, we're likely to need more and more of these imaging modalities to help us diagnose patients and to be efficient in our management. Retinal imaging is foundational to modern eye care, and as Adrian elegantly presented, we need fundus photography, OCT, FAF, and wide field imaging to help us diagnose these patients, plan treatments, and monitor treatments, and also to prognosticate these patients. Diagnostic precision requires a few things. We need to be accurate in the way we capture images. We need to interpret these images accurately and be very efficient in doing these. So we'll be talking about some practical pearls that can improve diagnostic accuracy and perhaps reduce errors in interpretation. So first, we have to know each modality. We're fortunate now to have many ways of imaging the retina, but each one provides a different dimension of understanding. So the most common test we perform is color fundus photography. So this provides a structural overview. And what's good about color photography is it does give us the ability to recognize patterns. In our center, we use the Clarus because we like the way that it gives us the true color image. It's basically what you see when you examine the patient at the slit lamp or with your direct ophthalmoscope. And it's very good for documentation. If you do serial photography, you can tell how patients are doing. Fundus autofluorescence gives us an idea of the health of the retinal pigment epithelium, and it helps us to detect subtle changes in AMD and inherited retinal dystrophies, as well as uveitis. So this patient with a sort of like a serpiginous type of uveitis was treated by us, and we tried several immunosuppressive agents, but you can see that over time her lesions worsened, and you can see these changes even before you can see changes in the color image. And this tells you that you have to adjust your treatment. Dye-based angiography gives us an idea about the health status of the blood-retina barrier and the choriocapillaries. Fluorescein angiography is applicable for the blood-retinal barrier, and choriocapillaries can be better imaged with the indocyanine green dye, which stays within the choriocapillaries normally. So both these dye-based methods allow us to detect disease activity by revealing leakage of fluid from these blood vessels. And it's very important for us to do these because they help us monitor disease activity and the response to treatment. So when you give the appropriate treatment, you will see the leakage decrease. And I think we're all familiar with optical coherence tomography, which provides cross-sectional imaging, as well as both qualitative and quantitative information about the different microstructures. Presence of fluid is very clearly seen in OCT, and as well as atrophy of the different layers of the retina can be seen with OCT, as well as OCT angiography. And this is also useful for us to monitor disease activity, especially if you have an image management system which can track how the patients do and illustrate how the relevant clinical parameters such as retinal thickness and cube average perform with treatment. And OCT angiography is becoming more and more a part of the standard of care. It's based on the detection of red blood cells passing through the vasculature, and it can reconstruct the vascular flow without the risks of fluorescein dye, as well as the cost of dye-based angiography. We also like that it provides us layer-by-layer analysis and helps us detect abnormal vasculature as well as areas of absent flow in the different layers of the retina and the choroid. And it's very useful to help us differentiate diseases such as choroidal neovascularization from central serous retinopathy. And it also allows us to deepen our understanding of pathology. So that patient we showed with the choroiditis. When we do the OCT angiography, you can see that the superficial retina is actually quite healthy. But when you go deeper and deeper, you can see that you start to have areas of damage of the choriocapillaries with absent flow and also extending down to the choroid. So this will help you figure out where the pathology is taking place. And it's also useful for monitoring because over time, if you see that these areas of absent flow are increasing, this is suggestive that whatever immunomodulatory treatment you're giving may not be sufficient, even though when you look at the fundus, things look stable. So visual field analysis, this is not just for the glaucoma people, it's also very useful in the retina space. This gives us an idea of the functional status of the retina and the choroid. So you can see in this visual field, there are blind spots. This is from that patient with the choroiditis. And with treatment, you can see that there's some improvement in the visual field, suggesting that maybe your treatment is having an effect. So the second pearl is that we have to be efficient in testing. So we only have limited time in the clinics, and we want to, order the test that we can arrive at the diagnosis and plan treatment with the least amount of time spent. In the Philippines, also, the only test that's reimbursed is the fluorescein angiography. No other test is reimbursed by the government system. And even patients with access to health insurance, frequently there's a cap to how much you can spend per year. So once you reach that cap, and you reach that cap faster if you do unnecessary tests, then the patients will now have to pay out of pocket. And even in rich countries like the United States, there's now a move towards decreasing Medicaid and reimbursements for healthcare. So I think we have to be more efficient in testing, and we have to order that right test to answer your question. And this will lessen the cost for the patient and healthcare systems, as well as minimize risks. Do you really need to do that fluorescein angiography to tell if disease activity is decreasing, or can we do OCT or OCT angiography, which carries no risk for patients? And if you have fewer tests but gives you the same answers, then you can lessen the burden on your practice and on the patients. So, for example, OCT can tell you if macular edema is responding to treatment just as well as repeated fluorescein angiography. Third pearl is to adopt a systematic approach to reading images. So you can develop your own system, but basically we should not just jump to that most salient feature. We should have a more structured approach and maybe look at things on a layer by layer approach, or spatially going from the periphery to the center. And then later on looking at quantitative information that's present. That way we don't miss out on any relevant findings. It's also useful to compare images sequentially over time. And you can tell using the Retina workflow easily if there's changes that's taking place over time. Next pearl is to correlate the imaging findings with clinical findings. So we have to remember that imaging is basically an adjunct. It is not a standalone and sole basis for making treatment recommendations. For example, in this case with the advanced AMD with the atrophy and scarring, if you see a little fluid on the OCT, do you really have to treat this patient? Is there any hope for improvement by treating this patient? I think not. So even though the OCT shows you the presence of fluid, we have to think that what is the point of treating this patient and make that recommendation. Next one is also to recognize normal variants. So sometimes we will see patients with epiretinal membranes, but the patients have good vision. So is there any need for doing any treatment? Also after surgery, sometimes we can see flattening of the retinal contour, and this is basically normal, so we don't really need to do anything else. In some patients, particularly hyperopes, you might see choroidal folds. So if you recognize these as normal variants that have no real clinical significance, then we don't have to intervene. So serial imaging provides a very important information, such as monitoring the progression of fluid in diabetics, or watching out for regression of choroidal neovascularization after anti-VEGF treatment, or monitoring the enlargement of geographic atrophy in patients with dry AMD. So monitoring this change in time is actually more important than just looking at a snapshot, and this will help you decide on what dosing you should give these patients. So for example, in this patient with wet AMD, but with both perifoveal and extrafoveal lesions, you can see here the retina workflow that when we gave these patients injections, there was a good response, and then we did laser treatment to this extrafoveal area, and we monitored patients, and we saw that the disease had quieted down. But with serial tracking, we saw that the intraretinal fluid was starting to come back. So at this point, we recommended further treatment. So the ability to do serial tracking of these patients can help us with diagnostic accuracy. And then next is we have to pay attention to artifacts, recognizing that there are many sources of artifacts in OCT, particularly OCT angiography, and we have to validate the quality of the image, and we should not hesitate to send the patient back to the technician to repeat the test if we think it's not an accurate test. And lastly, don't ignore the periphery. We're fortunate now to have a lot of ultra-wide field images, imaging technologies. We have ultra-wide field photography and OCT, and these tests should be, I think, better utilized to detect peripheral lesions. The central retina isn't the whole story, and peripheral lesions can give us a better idea of how a patient's doing. So in summary, diagnostic precision in retinal imaging comes down to several things. We should choose the right imaging modality, interpret these images systematically, correlate them clinically, recognize what's normal from pathological or clinically significant, watch out for artifacts, and track changes. So by adopting these strategies, I think clinicians can minimize misdiagnosis, optimize healthcare, and lessen the treatment burden for both the patients and healthcare systems. So thanks for your attention, and again, I'd like to invite you all to come to Manila for APVRS 2025. Thank you.
Thank you. This presentation is open for question. I have a question. So now you are using clouds and OCT and digital field. So how many computers do you have in your clinic? Because we need to open every image in the viewer. So how you use it in your clinic room?
Yeah, so we only have one computer, and it's connected to a very big monitor, and the system is when the patient comes, all the tests are done, and the nurses are now trained to put up either the retina workflow or the glaucoma workflow, depending on what the patient has and what you ordered. And when you walk into the room, the patient can actually see these images, and we use the Retina Workplace to basically navigate and view all these images and share that information with the patients.
Thank you.
I've been using the forum back in India, and I practically have a big screen put up like this, and I discuss with the patient similarly. Unfortunately, I don't have a glasses. I've got an Optos, so because I have a graphical screen, or nowadays all these newer HP screens also have it. So we swipe between the screens and we can show the Optos image as well as the forum at the same time. Makes a lot of difference.
Yes, and I think if you have the forum, you could actually maybe ask your local rep to somehow integrate the Optos images.
Thank you. Let's move on.
I thank the DICE and the organizing committee for the opportunity to make the presentation. Today, I will talk about 3D digital microscopic system for vitreoretinal surgery. My name is Joon Woo, working in Seoul National University Bundang Hospital in South Korea. These are disclaimers, and these are my financial disclosures. Today, I will talk about this order. First, I will introduce the 3D surgical microscopic system, ZEISS Artivo 850, and then I will show you my surgical videos. And finally, I will talk about my personal experience of using different 3D microscopic surgical system. First, I will talk about ZEISS Artivo 850. Before further presentation, I want to know how many of you are using the 3D digital microscopic system. Can you raise your hand if you often use 3D system in your routine surgery? No? Oh, no. Oh, just a few. Yeah. With that, I will continue my presentation. ZEISS Artivo 850 is the most recently developed 3D surgical system in the Artivo series. It uses a 3D visualization technology. Surgeons can handle all steps of surgery digitally, both in anterior and posterior segment surgeries. It is an integrated solution based on the established Lumera ZEISS 700 family, and it shows significant performance enhancement combining proven optical quality with cutting-edge digital technology. The most striking difference of ZEISS Artivo 850 compared to the other 3D system like Ingenuity from Arcon is that it uses the hybrid mode. With hybrid mode, you can switch intraoperatively between 3D visualization and the traditional optical system. So it is how we use the hybrid mode. There is a switch at the back of the body of the microscope. You can switch from the hybrid mode to digital mode. So when a surgeon is have great experience with the 3D surgery, then like me, I would not attach the oculars on the body. But if the surgeon is quite new in doing the 3D surgery, then he can attach the oculars and he can switch between 3D and the optical systems. And the assistants or nurses, people inside the surgical room can see through the 3D monitor, or he can choose the oculars. So this is the video how we what's the difference between the hybrid mode, the 3D system, and the oculars. So my nurse is now switching from the oculars to the hybrid mode. You can see the screen becomes brighter than the conventional mode. So it is quite bright, so I can reduce the light from the 75%. I reduce the light to 50% or lower. So if you compare the brightness of the monitors, it is the 2D 75% of light intensity. If I switch it to 3D, then you can see the field is much brighter. Even though I reduced the light intensity lower than 50%, it is still brighter than the conventional system. With this brightness, it's much easier to do the CCC in cataract surgery. You can see, you can compare the brightness of the red reflex. The other advantages, especially compared to the previous version of ZEISS Artivo 800, is that it uses the new HDR monitor. It's the 55-inch high-resolution Sony monitor. It was also improved from the prior version in terms of the brightness, color, and color contrast, etc. And it uses digital color assistant and smart depth of field function that are talked in detail in the later slides. This is about the digital color assistant. Previously, there was no filters in the RTVO 800. In the advanced RTVO 850, you can use the filters like vitrectomy blue. With this filter, you can visualize the vitreous more easily, and you can adjust the filters by the custom DCA filter. And with the red color boost, we can make the red color more vivid and more contrast to the surrounding the colors. It is quite useful when you are using the green dyes like the ICGA. And this is the smart depth of field. In default, it is set as high. From low to high or maximum 2 times, you can see the depth of field increase. It is focused on the cornea in the limbus. You can see the stone in the left side. It is very vague. It's not focused enough, but with the maximum of the smart depth of field, you can see it is more clearly visible. So this is the depth of field in the low mode, medium, high, maximum. You can see very clearly this stone, but you can see it is a little bit dark compared to the low level, but you can increase the light, then it is clearly seen in the cornea, conjunctiva, and also the surrounding parts. And also, it can be used automatically enhanced by the dynamic enhancement. You don't have to manually adjust this function. Now I'll show you the actual surgical videos I performed with the 3D digital microscope system, RTVO 800. This video is about the normal cataract surgery. Because of the downgrade of the image quality during the recording, and also it was recorded in 3D, but I have to convert it in 2D. There was some downgrade in the quality, and also there was a downgrade due to the projection compared to the high resolution monitor. So if you see the surgery in my OR, you will see it is much brighter and higher contrast. So now the surgery is already nearly over. In my OR, I use only the 3D surgery in the cataract as well as vitrectomy or surgical buckling. All the surgeries I do with 3D system. This is the video about the epiretinal membrane remover. You can see it is quite magnified, and the color is quite vivid compared to the red colors of the RPE choroid. So it is very rare for me to inject the ICG twice. Only a very small amount of ICG is sufficient to stain the IRM very vividly. In my hospital, I use 3 systems of 3D device. The one is the Zeiss RTVO 800, and I also use Archon Ingenuity, and sometimes I use the Korean Suntech Forms 400. These are the photos that I'm using these 3D systems in my surgical room. The most important advantage of using the 3D system, to my perception, is that ergonomics. It is really good for your health of your neck and spine of the back. I've seen so many senior professors and surgeons who stopped surgery or reduced the number of surgery due to their problem in the disc of their neck or back. So I think it can be a great solution to lengthen our time to do the surgery until our retirement. So you can see this left side I'm using the oculars, and the right side I'm using the 3D. I cannot lean back to the chair when I'm attaching my eyes to the oculars, but when I'm using the 3D, I can very comfortably lean back to the chair and my neck is very free. Sometimes I can stretch during the surgery. And when I'm using the oculars, I cannot, my head is fixed. So only my eyes should be moving. But when I'm using the 3D, I can move my head to see the periphery in the monitors. You can see in the front part, I'm using 3D, not fixing my head to the microscope. And also the assistant is also very comfortable. When I'm doing the surgery very long, such as 1 hour or 2 hours, he's much more comfortable than using the oculars. And for comparing the brightness, when I'm using the oculars, the brightness of the surgical field like the monitors in the back side. But the real surgical field is, when I'm using the 3D, is like this. You can see the contrasting brightness between the conventional and 3D microscope. And also there is a big difference in magnification. Because it's a 55-inch monitor, it can be quite closer, about 1 meter. So in my perception, is twice or 3 times larger, the surgical field. It is really efficient and comfortable when I'm using the macular surgeries. The forceps looks twice bigger. Yes, this is the contrasting difference between the size of the forceps in the conventional and 3D. And also the color contrast. I injected ICG dye in both cases. You can see the colors are quite different between the conventional and 3D system. And the most important advantage is also the education and surgical collaboration. This is me in the left side. I'm watching the surgery my fellows are performing. So in this case, I can see the same surgical field outside of the surgical surgery, and I can teach him and coach some surgical tips. If I have to teach in the conventional microscope system, I have to sit beside him, attaching my eyes to the oculars for 2 hours or 3 hours. It is really stressful. But if I am sitting back like this, I can go out and in and just quite relaxed and less stressful. And students or residents and fellows can sometimes come into my OR to watch my surgeries. And many of them can see and they can record my surgeries. They don't have to copy the images down after download. To conclude, the 3D surgical microscopic system have advantages over conventional 2D surgery, such as digitally customized surgical view, ergonomics, higher magnification, color contrast, education, and so on. Our table 850 is the most recent 3D surgical system with cutting-edge technologies. I believe it is optimal for all cases of both anterior and posterior segment surgeries. Thank you for your attention.
Thank you for sharing your experience. And this presentation is open for questions. So, is there any questions? Comments?
So, thank you to Professor Wu for a great talk. I'm jealous that we have so many toys to play with. So, Adrian pointed out something that when you were doing your cataract surgery, your your chopper had a light source. So, can I know what chopper is that? And is it with the system or something that only you have?
It's not. It's a special chopper that was invented by the Korean professor Joo Eun Lee. It can be. I think it can be only available in Korea, but it was already approved by the FDA. The company told me it is starting to export to other countries. It is good for some cases like very complicated surgeries like corneal opacities or vitreous hemorrhage. Is very useful. So I often use this device in the cataract surgery.
That's really cool.
Thank you.
I have questions.
Yes,
So you
please.
showed many tools, software for the color enhancement and do you use the O mode while you're vitrectomy, when you do a vitrectomy?
Actually, it is not efficient to adjust the settings during the surgeries or in different surgeries. Usually, I set the customizable functions optimal for my surgeries. Then I do all the surgeries in the standard manner. But in some cases, I ask my nurses or assistant to adjust it slightly when special function is required. And I also use the two surgical 3D systems, the ArtSize Artivo and Alcon Ingenuity. We have two surgical rooms. It was already placed in the two rooms. So I usually do operate twice a week, one day with JICE, one day with the Artivo, and alternatively so I can perceive the difference, and I can see how the advancement is made in each surgical system.
So, frankly speaking, which one do you think better, articulate quickly or
It's hard to define because two systems has its pros and cons. As this is JICE symposium, I would like to mostly stress on the advantage of the JICE. It has a higher magnification and a very more brighter surgical field and greater resolutions, and it is very easy to use because the monitors and microscope is attached, and it's very simple to just push the button and it turns on. But the Alcon system requires some bootings, and there are some, although it has some functions, sometimes it is a little bit complicated to adjust all those settings.
So I think the distance of the screen is important because we have, so the distance, so the microscope we can adjust, but I think the screen, the distance may be important. So is there any difference, the screen distance between the two systems, or you said you prefer which a distance of?
Yes, that's also important. Usually JICE recommends the distance about 1.5 to 1.75 meters, but for my case, I usually locate it more closely to 1 meter or 1.25 meters. That is up to the surgeon's preference. With more closer, the field is larger, and sometimes you should see right side to the left side if it is too close, so you can adjust to your preference.
My question is, what is the future function out there? Because since you're using the main 3D surgery systems.
Yes, I think the future will be like the remote surgery because it is the same surgical field in the OR. If it is connected to the 3D system in my room or home, even home, I can do, if the robotic system is due, I can do the remote surgery. So if I want to do the surgery in other countries like Philippines or Singapore, I can do the surgery in Korea too. That may be the future, I think. Thank you.
Thank you. I hope you enjoy the rest of the session. Thank you.
Thank you, Adrian, for the introduction. First of all, I would like to say thank you for JICE to held this prestigious meeting and giving me invitation to talk about my research related to this title. So I have no financial interest with this title. So actually, yeah, maybe we all know that diabetic retinopathy is still a very severe problem, and in the vitreoretinal field, and we know that diabetic macular edema can occur in any diabetic retinopathy stage. And my focus in this talk will be going to be about the relationship between the dyslipidemia risk factor to the progressions of the diabetic macular edema. So as a background, maybe recent years like 2023, we just report about the relationship between the serum apolipoprotein A1 and B and the associated with the progressions of the incidence of diabetic macular edema. And from these results, we can conclude that the higher of ApoA1 as a protein transport of the lipid have a higher risk of persistence and incidence of diabetic macular edema, and then the higher of ratio of ApoB per ApoA1 has a higher persistent incidence of DMO, although they have optimal treatment with the anti-VEGF. So the main of this research is like we want to make, is there any connections between the ApoA1 and ApoB and their ratio to the OCT findings? And in this research, we want to evaluate, is there any associations between the ApoA1 and ApoB levels to the OCT and OCTA changes in DME patients for 6 months. So we take all the patients with diabetic macular edema, with diabetes mellitus type 2, and the exclusion criteria we can see from here. There is no past infections, there are no myocardial infarctions, there is no history of liver disease, kidney failure, malignancy, or patients with the PDR with the vitreous hemorrhage and tractional retinal detachment, because we cannot make a very good diagnostic with OCT in this kind of patients. So this is the baseline. So we took patients with the OCT and OCTA. At this research, I'm using the Cirrus 5000, and then we check the ApoA1, ApoB serum levels, and then we do the anti-VEGF injection as indicated for 3 consecutive months, and then we take the fundus photograph, and in this research we're using the Clarus, and then took the OCT and the OCTA. And then if the patients still have the diabetic macular edema, we continue to use the intravitreal anti-VEGF as indicated. And on 6 months, we check again the ApoA1, ApoB, and the cholesterol levels. So we have about like 62 eyes. Actually, it's a little bit less than our plan, because the research happens in the COVID pandemic era. So we check about the central retinal thickness, foveal avascular zone, vessel density, and the perfusion density. So this is the baseline characteristic. We can see actually as a statistically significant, maybe the central retinal thickness. Yeah, of course, we know that patients with diabetic macular edema have much more higher central retinal thickness with, if we compare patients without DME. But the interesting part that we know that until today, we still find that HB1AC still have a strong relationship with the progressivity of the DME. But in this case, we see that the HbA1c still actually statistically not significant between the two objects, and maybe only the total cholesterol that is a little bit significant. But on the other part, the lipid profile and the apolipoprotein was the same in the baseline characteristic. So this is the blood chemistry characteristic according to DME progression. So after 6 months, we can see here that we try to make the group with patients with the persistence of the progressive DME, patients who have regressive DME, and patients still without DME after 6 months. We can see here that the ApoB, we can see that ApoB have a higher percentage in patients with persistence and progressive DME after 6 months of observations, although they already have the optimal dosage of the anti-VEGF. And the ratio was statistically significant too in patients with the persistence and the progressive of DME. And here we can see too that the elevated of the ApoB levels and the ratio of ApoB per A1 have a statistically significant in patients with the persistent or progressive of DME patients. And if we make the association between the apolipoprotein and CRT associations, we can see here that the ApoB statistically significant after a multivariate analysis with patients with the ApoB at the more than 122.5 have a higher incidence to have a DME persistence or a progressive DME after 6 months observations. So we can see here that with the higher serum ApoB levels at the first time the patients came to us, are 75.5 times are more likely to be associated with the increased central retinal thickness compared to the serum ApoB levels below 122.5. And if we make stratifications, we can see that the upper of the ApoB have a strong relationship with the higher of the CRT changes after 6 months of the observations. And if we compare the Apolipoprotein and the OCTA associations, we can see here, maybe from the ApoB, we can see that if we compare the association between ApoB and vessel density and foveal avascular zone area and perfusion density have a statistically significant, and the ratio of ApoB per A1 also have a good relationship with the perfusion density. So we try to discuss one by one. So this one is we can see here the high serum of ApoB levels are associated with 2.04 times higher of decrease of vessel density after 6 months of observations. If we compare if the patients have a lower serum of ApoB. And if we compare or associate with the foveal avascular zone area, we can see too that higher serum of ApoB are associated about 0.24 times having a larger foveal avascular zone area compared with the apolipoprotein below 122.5. And if we compare with the perfusion density, that the higher serum of ApoB levels are associated like 5 to 0.45 times having a decreased perfusion density. And this one, if we talk about the ratio, we can see too that the higher ratio of the ApoB per A1 more than 0.5 are associated with 5 times having a decrease of perfusion density compared if they have the ratio below than 0.85. So I think from this research, we can take a message that maybe serum apolipoprotein, especially the ApoA1, ApoB, can have a prognostic or biomarker in patients with diabetic macular edema prognostifications. And from this research, we can say that the higher serum ApoB levels and an elevated of the ratio more than 0.85 are sometimes associated with the retinal key change in diabetic macular edema. In this case, maybe there is some increase of central retinal thickness, the larger foveal avascular zone, reduce the perfusion density, and the reduce of the vessel density. So maybe in the future, we can make these examinations as a routine examination, so we can a little bit more predict with patients with the optimum anti-VEGF therapy in DME. We can tell the patient if they have the higher serum apolipoprotein B and the ratio. We can talk about maybe about the future of the treatment and all the prognosis of the patient. Thank you very much.
Thank you very much. Quite a fascinating study. Small numbers at the moment. I hope that you can continue to study so that you have a stronger sampling base. Are there any specific treatments that target ApoB and ApoA?
Yeah, that's the interesting part because we try to make some cooperations with the internal medicine, actually the endocrinologists. They told us like until today, they know that the apolipoprotein have much more stronger effect to the patient, the systemic effect of the patients with diabetes mellitus. But until today, they still not found is there any medications that can modify the apolipoprotein. So they just can modify the cholesterol, the lipid profile with the LDL, VLDL, and the cholesterol. But because this research was, we have the cooperation with the endocrinology too. They said that maybe this research can make us as endocrinology in the future to found any medications or any treatment to make the apolipoprotein effect in the body. But until now, no, they don't have it.
So I have another question. So you mentioned it's more likely to be progression to DME.
Yeah.
Did you look also at response to anti-VEGF? Are these people with the higher ApoE less responsive to anti-VEGF?
Yeah. Yeah. So on our first report, I give in the background that we try to give the patients with the same regimen, with the anti-VEGF, and so we just continue the study, and then we've seen that patients with the baseline ApoB, higher ApoB and lower ApoA1 have a tendency to a little bit refractor with the treatment. So that's why sometimes we try to tell the patients if we have these conditions, like maybe you will have much more frequent injections, or maybe you will have a little bit not have a good effective effect. But I think the little bit downside of this project that we just used one anti-VEGF because we didn't make any comparable with the other anti-VEGF. So maybe in the future, if we can make with different anti-VEGF and related with this apolipoprotein, it can reach much more effect with this study.
Actually, I think there is a strength that you only use one anti-VEGF.
Yes.
Because if you had several anti-VEGFs,
that will be biased.
You could attribute the different responses to that anti-VEGF. The fact that you use one, I think is also a good start. Right? Any other questions or comments? I think this is a promising field. I mean, we've been waiting for something that we can test in this field to give us some kind of indicator. What do you think is the most likely mechanism for this persistence of DME and unresponsiveness to anti-VEGF?
So actually in this research, I thought that maybe sometimes we can see that because we talk about the systemic conditions, like this apolipoprotein actually is like a protein transport. So sometimes we a little bit focus like in previous report told like this protein transport sometimes is much more effective way to see compared to HB1AC. So there a little bit some report before that we always talk to patients, like patients will have a very refractory DME. So how is your level of HB1AC? It's always like that. I mean, like that's a routinely things that we should do. But the first things that why I make this research, because I found that maybe this apolipoprotein can be more, in the body can be much more have an effect, because we try that all the lipid, if they have a very bad protein transport, sometimes the relationship to the cholesterol things to the retinal vascular is much more less. So I think that's the reason why maybe in the future these things, if we can modify the apolipoprotein, can have a better effect for our patients.
Yeah, I think we don't fully understand the mechanism of the relationship between the lipoprotein and the lipid itself. Right? We've had many studies showing that there's been no correlation between severity of DME and cholesterol control. Maybe with respect to hyperreflective dots and lipid exudates, maybe. But even then, that's not really conclusive. So this is, I think, an interesting angle. I just wanted to comment that OCTA in the presence of persistent DME carries a lot of artifacts. So vessel density and perfusion density. Sometimes it's masked by the presence of cystic fluid. So one has to be very, very careful that you are not over-reading the OCTA. Any other questions, comments? If not, thank you very much.
Yeah, thank you.
Hi, hello everybody. This is not really so much of a research paper, but it's a bit more of an overview on how OCTA over the years has changed our understanding of retinal diseases. These are my disclosures. And, we know that OCT, in no doubt, has transformed retinal diagnosis and management. You can see that over the time, from time domain to spectral domain, it has really moved our treatment regimens and has affected our treatment regimens. For OCTA, however, I think it was not such a revolutionary device. And even till today, there are still many naysayers about whether or not OCTA is useful in clinical practice. And this is a very interesting commentary that I read recently, whether OCTA is essential or gimmick. So is it like something where you definitely need it in clinic? Or is it like a luxury Birkin bag that you can, it's nice to have, but it's not really necessary for your clinical management? So I think although we still have this debate, we do know that OCTA has changed our understanding of retinal diseases because now we are able to look at early and subclinical diagnosis. We are able to also monitor and predict disease progression, and also we can understand disease pathogenesis. So we'll just go through some of these areas. So when you look at early and subclinical diagnosis, firstly, now we can detect non-exudative macular neovascularization. In the past, because we would not see any fluid on OCT, we would never go and do a fluorescein angiography or ICG on these patients. But now we can do a simple OCTA, and you can see that actually its prevalence in the fellow eye who have exudative AMD is about 6 to 27%. And you can see normally we now know a shallow irregular RPE elevation or double layer sign as a very common sign for OCT itself to detect maybe that there is a neovascularization underneath. And not only that, it's really important we do detect these neovascularizations because they hold an 18-fold increase in developing exudation in 2 years. So even though we don't really treat this non-exudative macular neovascularization, we should use it to make sure we can look at how we can risk stratify patients and monitor patients more closely. You can see also that the OCTA growth of the macular neovascularization is associated with the risk of exudation. So when you do consecutive OCTAs over time, you see when there's an increase in the area of more than 50%, we know that there's a much higher risk of exudation. And also some studies have even shown that actually when there's increasing macular neovascularization, there is some protection against atrophy. So you can see that this non-exudative macular neovascularization with the SIA really requires closer surveillance with OCTA. The other thing is this hyperreflective dots. Before, we would only see hyperreflective dots on OCT. And now, hyperreflective dots can mean many things. Pigmentation, sometimes signs of inflammation, macrophages, and things like that. And now with OCTA, you are now able to see the superimposed flow signals on the hyperreflective dots that may be early changes of type 3 neovascularization before they become a full type 3 neovascularization with exudation. And this allows us to then detect and monitor these patients with hyperreflective dots that have flow more closely. Again, just looking at OCTA features of active macular neovascularization, just by looking at patterns such as the dark ring around the vascular membrane, the shape with a lot of peripheral anastomoses, as well as then also contrasting with the much more mature, stable membranes, allows us to also further characterize what macular neovascularization looks like without the need for FFA or ICGA. You can see also this has really changed in my clinical practice. I oftentimes, when I see a central serous chororetinopathy, I do a OCTA to look for any CNV that could be amenable to treatment. And I think a lot of times in the past, when we treated central serous and it was very variable, the response to treatment, it was a lot of times because some had secondary neovascularization and some did not. And so really it expands our treatment options and helps us to treat patients in a more personalized manner. You can see also OCTA can be used to screen high-risk diabetic retinopathy patients. You can see in this fundus, it's largely, featureless, but the HbA1c was drastically dropped recently. The patient, had really good vision. But when you do the OCTA, you can see there's obvious signs of neovascularization. And then you can diagnose the proliferative diabetic retinopathy even without doing an angiogram. And this really interesting thing also now that we have more quantitative measurements that are more reproducible with OCTA, we know that the perfuse capillary density near the FAZ is much higher in patients in diabetes without DR, showing that the changes in the vasculature happen even before any clinical signs happen. And you can see that in the PCD actually goes down when the patient does develop the non-proliferative diabetic retinopathy because of the increasing capillary segments. So now we are able to see preclinical disease before we actually see the clinical evidence signs. The other thing that's really important that OCTA has done is really looked at monitoring and predicting disease progression. You can see here in a cross-section of OCTA, these are type 1 neovascularization underneath the RPE. And you can see that when we treat this patient with 3 injections, then markedly the vessel complex changes. They get pruned. They often use this word. The peripheral vessels get pruned away, and a much more mature membrane starts to form. And you can see that the lesion reduction, regression, and pruning makes it a mature neovascularization, which is oftentimes a lot more stable than the initial stage when the patient has not been treated. Same with the type 2 neovascularization. You can see this is the neovascularization that is in the subretinal space. Similarly, with treatment, you can see that the peripheral vessels get pruned. And when you treat it for a longer time, it becomes a more stable vessel complex. And in fact, now we know that a lot of these CNVs, they never really go away. But by us just controlling them and making them a sort of a more mature membrane, we can have the patient still maintain good visual function and inactive lesion. And so this allows, when we do OCTA now, we can do it in every visit without the need to do angiography, and this helps us to really look at how they respond to different intravitreal agents now that we have more and more in the horizon. And you can see similarly here, this shows actually the neovascularization actually starts to decrease after the first day and starts to increase by by day 30, which is why, you know, in the past when we only used ranibizumab, we had to start giving it every month, you know, and this helps us now when we have newer, longer acting agents. If we look more at the vessel complex itself, it helps us decide sort of our treatment intervals and in much more quicker succession, and so we can try and push the patient to longer treatment intervals faster. Similarly, for the type 3 neovascularizations, as I mentioned, it is most nicely seen in cross-sectional OCTA, where you can see there's a very linear hyperflow signal. And you can see that the response to type 3 neovascularization, the neovascularization actually grows before it starts to leak. So you can actually predict the pre-exudation recurrence before it actually leaks. And this also helps us to taper our medications accordingly. You can see for proliferative diabetic retinopathy, when we do use protocol S treatment, you can also see in succession, OCTA is a good way to help you monitor the regression of new vessels. And also, when you start to stop the patients on injections, it helps you to see when the vessels are recurring and when you may need further treatment. The other thing that has also come up a lot recently, because the quantitative parameters have become increasingly better and more reproducible, you can see that we can even look at the size of the FAZ area, the lower vessel density and fractal dimension, to look at who will be faster progressors. And also you can look at how more risks a patient gets DME by the lower vessel density. So these are all exciting matrices that we are starting to look at more closely so that we can better predict who are going to be progressors versus who will be stable. So really, I just want to conclude by saying that OCTA has changed our understanding of retinal disease by helping us do early subclinical diagnosis, both in AMD and in diabetic retinopathy. And also we can look and monitor and predict disease progression in these 2 diseases, and we can even predict progression even before the actual exudation or activity happens. Thank you very much.
Okay, now you didn't answer the question. So is this a necessity or a given?
So I think increasingly it's about how you use the OCTA. And I think increasingly when we know what we are looking at, I think it becomes a necessity when you can use it well. So in OCTA, when you see a membrane, you see proliferative diabetic retinopathy is there, and then you don't need to go into your angiography. And I think increasingly when you can depend and be sure that you can see the vessel complex of OCTA, it becomes a necessity so that you can save the patient for angiography. And I think that's where the necessity comes from.
Thanks. Any questions or comments? Yes.
Yeah, great presentation, but I think the one that, for me, do do you think that maybe in the future we can have like some value or some score for the FAZ area, facial density or perfusion density? What is the the minimum? Because we know that this feature can predict about the diabetic retinopathy DME before it happens clinically. But yeah, until today we just use this one as a comparison. I mean, like after the patient has it, and then 3 months later, okay, there is some decrease or something like that, but we don't have any.
Yeah, we don't have absolute normograms, for example.
Yeah, so the normograms we tried doing sort of normative OCTA, but it's very annoying because OCTA, the normative normograms only work for the same brand of OCTA and the same version of that same brand of that software.
Yeah.
So then when you move to a different brand, this nomogram is like, it doesn't work anymore. So, until we have sort of a more nomogram over a lot, or I think what people are developing now is sort of formulas that can translate, let's say, an SS OCT into a swept source OCT FAZ. Once we have those, then you can do a little bit like the Harvey visual field where there's the mean deviation of the normative one. And I think that will give us a lot more information of like what is a normal FAZ versus a not a normal FAZ, what is a normal vessel disease confusion. Because now all these numbers doesn't mean much to us unless you do a longitudinal comparison, right? So I think that's the future when we have more of these things. I think that would be very useful.
I think you raised a very important question of how we use quantitative matrices for OCTA. Some of that will start to come out from the trial. So you look at the more recent drug trials, the anti-VEGF, ILA-8 and faricimab. Certainly, I think the complement factors also. They collected quite a lot of OCTA data. Right? So that will go a long way in helping us determine what is normal and what is abnormal. Currently, it's mainly qualitative and also comparative. Right? I want to ask a little bit about the role of OCTA in polypoidal. You know that we are moving away from ICG as much as possible, sometimes in using OCT to diagnose polypoidal. And how often can you tell reliably that you are dealing with a patient with polypoidal, first in diagnosis, and then using OCTA changes to determine response to treatment?
Yeah, so I think for polypoidal, usually at this stage, OCT is probably, even OCT alone without the OCTA is also good enough to sort of find the thumb-like projection, the circle and things like that inside the PET. But of course, the addition of the OCTA can help you see the flow within that signal, and sometimes you can even use that to plot where you may want to focal laser with extrafoveal, or even PDT in the cases where you can't do a whole ICG. You may even be able to plot your PDT based on that. So I think if you combine the OCT and OCTA matrices for PCV, it's in the level of like 90% or more detection rate. And I think the beauty about the OCTA and the OCT is that you can then look longitudinally at polypoidal closure, which is a good outcome measure also when you determine how stable a lesion is long term. So I think these are the ways I feel that OCTA does lead. Sometimes you are not very sure if the polypoidal lesion has closed or not with the OCTA, and you see the flow, then it's not. But the cross-sectional OCTA for the polypoidal, I think, is much more useful than the on-fast sometimes. Yeah.
I want to just pick up on a few points that you made about CSR. I think it's really important if you have an acute CSC to look for underlying choroidal neovascularization. There's a great masquerade, and you need to treat it differently. You have to treat it more aggressively rather than observing, and you have to treat with anti-VEGF. So I think CSC is a well-known indication for it. The second one is PEDs, right? I found OCTA quite useful in separating serous PEDs, pure serous PEDs, from vascularized PEDs. Maybe I can ask Seung, how do you use OCTA in that respect, and how useful do you think that is?
I think so the very good point. So we can differentiate the vascularized or the non-vascular serous PED with the OCT angiography, and we can check that the follow-up monitoring. So we don't need to take the ICG image after 3 months that start the treatment. So we can check the early change of that kind of vascularized PED with OCT angiography, and also we can check the BVN and whole configuration, because because there's no dye leakage, so we can exactly see how it looks like. And recently we realized that the circularity of a whole lesion is important to response on the response to treatment. So if the lesion is round, on OCT angiography, the response is better than the very irregular shape.
So that's a nice point. The circularity index has now actually been put forward as also an endpoint in itself. Right? I just want to emphasize that segmentation is so important when you're talking about OCTA, especially in the presence of RP elevation. In the past, this was really terrible. I mean, now it's improved so much. The RPE fit, for example, the ability of the angioplex to segment the RPE is really critical. Otherwise, there is no way you can make any kind of conclusion if you can't segment. And the ability to manually sort of adjust the slab is also equally important. All these are available on the forum and on the retinal workplace. So I think that's one aspect that ZEISS has done well.
Yes, that's the really important point also. So usually the polypoidal lesion located on just underneath of IPE. So if we make a segmentation the base of PED, actually you don't segment the polypoidal lesion. So you have to follow the IPE line.
Yes, exactly.
Also, just to add on, a lot of these very big PEDs that have vascularizations that you can miss sometimes are creeping vascularizations from the corner that go underneath the RPE surface. So it's like, so you need to really segment it just below the RPE. And sometimes with the big PEDs, the segmentation lines are not so accurate. So you need to really focus just below the area where there's a creeping. And usually you can see it because it's a bit hyper-reflective versus just a normal RPE.
And just one final point about the use of the OCTA in hyperreflective dots and subretinal hyperreflective material. Very often the shroom takes a long time to resolve, even after successful treatment. So one good way of determining whether you're successful with treatment is to look for the flow signal within the shroom complex. And if there is no flow on OCTA, then it gives you some reassurance that you can wait for the shroom to finally reabsorb. But if it's still active or you see increasing signals, then that may be an indication to keep going with therapy. So as we learn more and more about OCTA, there will be very important, I think, observations that will help us in the coming months and years.
All right, nice to meet you. Now, thanks for introduction. So actually, I prepared a couple not really mysterious cases, kind of straightforward cases to share with you. So I do not have any financial disclosures related with this in particular talk today. So the case number one is glaucoma patients that I treated as a retina specialist, and I got helped by anterior segment scanning or CT scanning device. So this is a 77-year-old man with flat anterior chamber. So he had a history of trabeculectomy 6 months ago, and 3 weeks ago, he had a black needling procedure with mitomycin C, and because of hypotony and continued flat anterior chamber, our glaucoma specialist there here in our hospital did some suture on sclera flap a week ago. So this is 4 days after the sclera flap suture, and because of the continued collapsed anterior chamber, the glaucoma specialist tried to reform the anterior chamber by injecting viscoelastic material in anterior chamber. But something wrong. Even though he tried to put some viscoelastic in the anterior chamber, the viscoelastics just pushed away because of a very tight eye. So I was called in, and I looked at, and I tried to help her by tapping some fluid from vitreous and lower intraocular pressure, and then I could reform the anterior chamber by injecting the viscoelastics. So this is the picture the next day morning. The chamber depth is deep enough, looks stable, but it didn't stay long. But the following day, the anterior chamber collapsed again. We did the same procedure again, same thing happens like this. So this is the day when the chamber collapsed, and this is anterior segment or CT scan of these patients. So what is this condition like? and what would be the next and best possible step.
Anyone?
Anyone? All right. Pardon? No, I didn't do that. At the time, I couldn't see the fundus very well, so I didn't have to get on B scan. Nothing there, nothing remarkable.
It's quite interesting. The anterior segment OCT and maybe a UVM will tell it better. It's a bit like
But UVM is not, and I do not have UVM here. But I think anterior segment OCT scan is just good enough to get.
Looks like an aqueous misdirection.
Yeah, right. So after talking with my glaucoma specialist, we talked that it is malignant glaucoma and like this. So what I did was zonular hyaloid vitrectomy. As you can see, eyeball was formed, not formed. And the first step I did was I tried dry vitrectomy without turning fluid on. And after lowering intraocular pressure, I could reform the anterior chamber. And I did complete vitrectomy. And I tried to see if there is posterior snake, and if there was, I tried to relieve it. And then I tried to make a rhizotomy using vitreous cutter like this. And next step I did was I approached it from behind to make an opening and a capsule. But the capsule was fibrotic, so it was kind of hard. So I tried to use second instrument, but somehow it was difficult, so I used intraocular seizures and forceps to cut it off. But later on, unexpectedly, I found out that intraocular lens was blocking here. There's a lens, plate type haptic was blocking there. That's why it was so difficult to cut the capsule from behind. So somehow I had no choice but to enlarge the rhizotomy all the way to the edge of plate haptic of the intraocular lens, like this. So now I can, penetrate from the behind all the way to the anterior chamber. So there is, free and pass from behind to the anterior chamber. So that's it. So this is 2 days after vitrectomy. A deep enough anterior chamber dip, although choroidal detachment develops afterwards because of hypotony, but nothing, not really bad. So after a couple of weeks of conservative management, cortical, it's just gone. And good thing was that anterior chamber was stable, dip, so it looks fine. So this is anterior segment OCT scan, from here, before the operation and after the vitrectomy. So this anterior segment OCT scan was achieved using the series. This one, the series we are using every day in our retina practice. If we attach this in the anterior chamber or in a cornea module here, we can take a very good anterior segment scanning OCT scan like this. So what is malignant glaucoma? As you mentioned, there is a lot of way of describing this one like this. But I like this review journal here. The author suggested to use, they can be classified in two. One is acute fluid misdirection syndrome for the cases we often see during the phaco emulsification, right? Another one is chronic fluid misdirection syndrome, like this case we are talking today. So how to cure? So we have to major pathologies around here because of zonulopathy or ciliopathy or whatever, something wrong may prevent aqueous fluid from moving from here all the way to the anterior chamber. So you have to make a new route for the aqueous humor to pass it through. So from here, iridotomy and zonulectomy or capsulotomy, and then anterior hyaloidectomy. That is the key for cure. So just debulking the vitreous is not enough. If this new route is made, I think complete vitrectomy would not be really needed. So so what I did was either zonal, actually here either capsular hyaloid vitrectomy, and after 2 months after vitrectomy, the patient looks fine. So that's it. So take-home message of case number 1 is actually, OCT device and a Sirius is really kind of multifunctional tool from anterior all the way to the posterior. It's a very handy tool for us. And to treat the chronic fluid misdirection syndrome, either the journal or the capsule vitrectomy is the key for the treatments. That's it for the first
let's
case.
pause here for some discussion on this first case. Thank you very much. Any comments, any questions? Not so commonly seen nowadays, Christmas direction, but nonetheless, I think it's quite important. Have you ever used the anterior segment attachment to the serous for OCTA?
OCTA, I haven't really tried it. Is it possible? Actually, I didn't really imagine that could be possible.
These eyes doesn't have it.
It's not, I've seen some images from the anterior segment. It's not great.
And I try. I give it a try.
I tried, and the resolution is not good enough.
Oh, you tried it.
Compared
Okay.
to other
I think that the Plex Elite
Plex Elite maybe.
is good. Yeah.
But Plex Elite, there is no this kind of attachments. The attachment is only for your serous, I guess.
Yes, but I think that there is an attachment to Plex Elite for anterior segment.
Oh, really?
There is.
Oh, you have.
Yeah, there is.
One of the limitations of the anterior segment attachment, it doesn't give you full white to white. So the cornea specialists really want to have the appreciation of white to white, which this one does not allow. So I hope the Zeiss actually, they're not here, but hopefully they will work on an attachment that allows that. Currently, I think only the Pentacam gives you consistent white to white assessment. I think the clue here with the anterior segment OCT was the asymmetry of the angle. If you look at the initial diagnosis. So maybe that will be a clue. Sometimes we see this also in subluxated IOLs, causing either UGH syndrome or sometimes just capsular fibrosis. So I think the anterior segment OCT is a very valuable tool. Do any of you have experience with anterior segment OCT? It's a simple attachment to the serous, so it's actually a very cost-effective way. Okay, if not, let's move on.
To the second case, actually. It's now the Retina case. Actually, I've prepared in the first case because I thought, this session was a collaborative session with glaucoma, like as we did, yesterday. But today I found out that this is all Retina people here. All right, so this is a Retina case. So this 72-year-old man with a subretinal fluid, because of fluorescent leakage and subretinal fluid and something wrong here, I did 3 loading injections of anti-VEGF, but after the loading injection, there's almost no change. So what is the next step? So switching over to another new anti-VEGF, or just wait and see?
Before you carry on, do you have autofluorescence?
They should be great. Okay.
Do you have autofluorescence?
No, I didn't. Because actually, I'm not a big fan of autofluorescence.
Yeah, we're really looking for vitelliform here, right? Sometimes you can be boxed. Even with vitelliform, you can have active CFD. So it doesn't mean that vitelliform equals no treatment. You still treat, but to a point that if there's no response, you stop treating. Right? What's the visual acuity?
0.7. Fairly
pretty good with this. Fluorescein, ICG, or even OCTA. Do you have any?
Yeah, right. Can you move on? All right. So anyway, I'm going to show you this. Around this time, Plex Elite was installed in our hospital. So I took OCT angiography using Plex Elite, which is swab source OCT angiography, and to my surprise, I couldn't see neovascularizations, MMV here. So I stopped the treatments and just wait and see. So in our practice, we often see these kind of lesions that looks like CMV, but actually they are not. There are a lot of lesions that look like MMV. So among them, vitelliform lesions are the most important, the one. Whereas the best disease is kind of a genetically inherited disease, but acquired vitelliform lesion is the it's something that can be seen in elderly patients that has no genetic backgrounds. So what we call an acquired vitelliform lesions. Actually, this term was introduced by Dr. Freund et al. Years ago. And recently, there is a review paper, cross-sectional study that looked at the patients with acquired vitiligo lesions in intermediate AMD. The key finding was that Pachy vessels around macula was clinically significantly associated with these acquired vitiligo lesions. So there is a recent new terminology that is Pachy vitiliform maculopathy. I like this term. So I think this Pachy vitiliform maculopathy could be one of newer category of pachychoroidal spectrum disease. There is possibility. So how to diagnose this acquired vitiliform lesions? So as you can see here, fluorescein, ICG are sometimes misleading our diagnosis and treatment. So osteoangiography is very useful. So as you know, we already discussed, especially SWAP source osteoangiography is a real handy tool. They can demonstrate macular neovascularization very well from the type 1, type 2, RAP, and PCB, you name it. All of this the macular neovascularization can be demonstrated very well in a SWAP source osteoangiography. So SWAP source osteoangiography is very useful for differentiating them. Can you tell which one is which? One is macular neovascularization and one is vitiliform. They look almost the same, right? Even with this one, they look almost the same. But this one is macular neovascularization here. There is no leakage. Now there is no CMV visible here. It's a vitiliform lesion. So again, osteoangiography is very useful. So how to change over time? This the picture, and recently, luckily enough, these patients visited me again recently. So I took an OCT scan here. The fluid is gone here. Now we can see the atrophy of macula, around macula. But as you can see here, the visual acuity dropped a little bit. It's not really bad. So this kind of really common outcome of this vitiliform lesion. So natural course of vitiliform lesions, something like it looks like this in the beginning, but with time, gradually getting observed, so you can see hyperreflective foci, like a transretinal migration of this debris, and then really some of the patients, show complete recovery very rarely, but most of the best possibility is that they can end up leaving some atrophy of photoreceptor and an RPE in the long run. So take-home message of the retina case number 2, we often see the acquired vitiliform lesions or Pachy vitiliform maculopathy. Osteoangiography is very useful for the diagnosis, and we can avoid the risk of an unnecessary anti-VEGF injections. That's it.
That's a nice case, thank you. Some important highlights here. I would still urge you to consider autofluorescence in some of these cases. I usually have that as a baseline. Even in CSC, you'll be very surprised. What is the extent of the damage to the RPE and the atrophic tracts and so on? That tells you chronicity.
Okay.
So an autofluorescence is always useful. You don't have to use the blue light autofluorescence all the time if you're worried about toxicity. Any comments, questions? A nice case. Vitiliform is quite an important issue. Yesterday I presented a case of a cold rod dystrophy with vitiliform. So vitiliform is not a diagnosis in itself. You need to be able to then differentiate primary, secondary vitiliform lesions. I don't quite like the term Pachy vitiliform maculopathy. Anna, what do you think?
I mean, this Pachy is like now the prefix for many different diseases, right? It's Pachy choroid spectrum. So
I mean, the problem
I guess
with that,
the problem is that the Pachy definition of Pachy choroid and stuff like that also is, still there's some debate about that. But I think, I guess, to be honest, Pachy vessels are very common. So, I think, it's interesting to look at the choroidal changes in relation to the vitiliform, just in terms of also understanding the pathogenesis and things like that. I think that's probably the value of this.
Yeah, the problem is if you just label it as Pachy vitiliform, you are saying that the vitiliform material is somehow caused by the Pachy choroid, which may not be. I mean, it could just be an association and a common observation. Seung, what do you think? Pachyvitelliform maculopathy, is it a real entity, or is it just David Seraph and Kevin and Bailey trying to coin up new diseases after their names?
I think so. As Anna mentioned, it's really hard to, how can I say, how to say it is pachy or not in these elderly patients. So yes, probably if there's thin choroid, we don't see that. So I agree that the term, but anyway, it's really hard to say it is really pachy or not.
Have you ever tried inadvertently doing PDT or combination therapy for vitelliform lesions? Or have you ever seen the reaction to that?
It's not good, right?
It's not good, absolutely.
Very bad.
Have you ever seen that? I had a patient who was referred to me because had a very bad reaction to PDT, and in both eyes actually had vitelliform lesions. The right eye was thought to have CNV, and this was in the earlier days when it was PDT monotherapy, and the second eye unfortunately was not treated yet. And they get a very massive subretinal fibrosis. It's a little bit like trying to treat with PDT flecks in fundus flavi maculatus. Never touch the flecks. They end up with fibrosis.
Okay, let me just briefly touch upon this, about packets or something. These are a lot of patients that I can collected so far. So as you can see here, this packet vessels here, or are they packet choroid? Some of them are packet, but some of them are not. So the thing is, in the paper there, the proportion of the packet vessels in the development lesions only about 40%, not less than half. So some of the development lesions have packet things, but some of them are still do not associate with packet vessels.
No, I agree that. I mean, very often you do see packy choroid in association with the vitelliform. But is there a cause and effect, or is it just an observation or an association? That's my problem with the term.
I mean, in the picture here, that one maybe is packy, that one, but then the middle one there is definitely not.
Right.
I mean, the middle one is so thin.
Right, exactly.
So,
right.
At the end of the day, I think that classifying it must have a reason. I mean, must have some practical usage for it. So currently, I can't think of any practical usage calling it a pachyvitelliform. Unless you're going to target it with some kind of therapy for the packy vessels. So let's say you assume that this is a result of packy choroid, and we later have a treatment, a very effective treatment for packy choroid. Then I think I would accept that classifying it this way would have some clinical usage. Okay, but thank you very much.
Thank you very much.
Hi, good morning everyone. Thank you for having me again to present this case that we manage our center. My disclosures, none of which are related to this case. So I name it a challenging case so as not to give away any clues towards the diagnosis of the case. So this was a 44-year-old female. She has seen multiple ophthalmologists in the past decade or two, and she has a significant past medical history of she has asthma and she's on steroid inhalers. Other than that, she is systemically well. She was referred for a second or third or even a fourth opinion on having chronic central serous chorioretinopathy. So on examination, her baseline VA was 612 in both eyes, IOPs were normal, and anterior segment examinations were normal as well. So this is a fundus photograph of both eyes. You can see the mottled appearance of the macular region. There's a presence of a serous retinal detachment in both eyes. The OCT confirming the serous retinal detachments. The choroid is also thick here. You can see the presence of very large choroidal vessels. And you can see also that there are some small stalactite depositions underneath the neurosensory retina, which is consistent with something of chronicity. Other than that, I don't see any other lesions that is of significance on the OCT. Adrian loves this, the autofluorescence images showing the chronicity of the damage of the subretinal fluid in both the eyes, very large areas of hyper as well as hypo autofluorescence in both eyes, mainly in the posterior pole. Fluorescein angiogram was done for the patient, multiple areas of pinpoint leakage and extending to greater areas of leakage as well. So at this point, I'd just like to ask the audience, any thoughts? Is it consistent with the diagnosis of chronic central serous chorioretinopathy? Seems to me that it does.
Maybe the question should be, are there any flags that this might not be CSR? Yes.
It's quite symmetric from both sides.
Symmetry?
And also, if you have a chronic CSR, maybe you can see the gravitational tract.
Yeah.
But this doesn't appear there.
I think the history is quite important, right? Whether or not the fluid has been persistent for a decade, as you say, in which case, then this is not consistent. You will see tracks already. Or could it be acute on chronic sort of episodes? And this might be an acute episode, it resolves, and then you have another acute episode, that might explain. But very interesting, right? This is not quite what we expect.
And the leakage, I'm not sure, in the beginning, is it like pinpoint or is it diffuse?
Oh, so multiple points of pinpoint and then spreads out and becomes diffusely leaking over the whole entire body. Periphery is fine.
Early or late leakage?
More late.
I mean, if you look at the angiography, the leakage is only in the sides, right? I mean, actually the macula itself, even though the fluid is at the macula, the leakage is not so not so clear there, right? It's more on the sides, and like I said, the symmetry I think is quite good.
Yes.
I think the important is the symmetry between the both sides, and also there is some discrepancy between the leakage patterns that we usually see in the CSC. So it may be a little related to some genetic background. We have to have a further history of the family history, etc.
So there isn't any family history. The parents are staying in a neighboring country, and we didn't get to examine the parents.
Any ICG?
We didn't do ICG at this point in time.
I mean, normally for a CSC, certainly chronic CSC, I would like to have an appreciation of the choroidal hyperpermeability. That's an essential feature of chronic CSC.
All right, I'll move on first. So we had a whole list of differentials. The patient was not complaining of any eye pain or eye redness. She was systemically well, except for the inhalers. She was not on any other medications. She wasn't on any supplements or any traditional medicines. We observed the patient for 6 months at this point in time. Fluid is still present. At this point, we repeated a fluorescein angiogram and ICG angiography as well. The fluorescein angiogram showed practically pretty similar findings as what we had about 6 months ago. In this case, we also did ICG angiography, and there were large choroidal vessels seen as well. No obvious CME network seen on the ICG angiography. No late plaques staining as well. What will you do?
Anyone?
I heard observe.
You need to do anything.
So the vision is stable. So at this point in time, the vision is still stable. All right.
We don't have a diagnosis.
Yeah, we don't have.
Yeah. Any diagnosis from the audience? Yes. Biomarkers. But without the flags.
Yeah, the similar, but I found some reasons.
Okay. This would be atypical from my point of view. We often want to see at least some hyperautofluorescence on the nasal side of the disc.
I also suspect best is
Yes, yeah. Certainly, I think best is one of the mean differentials, the liquefacted stage of best disease. That's also possible. In which case, then you should do EOG.
So, well, I have more to the story. So, we didn't do EOG at this point in time. The patient underwent bilateral half-fluence PDT. So this is 3 months post-PDT, fluid is still present. Started on the trial Apolipoprotein, which the patient couldn't tolerate, so stopped it quite quickly. 10 months post-PDT, still the presence of fluid. And What would you do at this point in
Can I
time?
ask, where did you apply the PDT?
Because I'm not the managing physician, so I'm not really sure exactly where the PDT was applied on. But if I didn't remember wrongly, looking at the markings on the Heidelberg, I think it was applied at where the leakage
FA.
on FA were. Yes.
How many of you treat with PDT based on FA? FAD? How about ICGB? So I think most of us still doing PDT will want to treat based on ICGB, right? Because actually that's the point of it. We are not doing focal laser to close RPE leakage. We are trying to do choroidal remodeling to reduce vascular hyperpermeability. So I think the basis for PDT currently is to treat the underlying choroidal lesion. And therefore, I urge all those who do PDT, or at least in your centers, to ensure that there is a record of the zone. I think that's medical legal actually. Because if you end up with, let's say, a rip, right, or severe atrophy, I want to be able to go back to your notes and say, where was the PDT applied, half fluence, full fluence, combined, whatever, right? So in this case, I think documentation of where the treatment zone was applied is equally important. Because if it doesn't work, maybe you applied it to the wrong area.
Yep, fully agree. The only problem is because sometimes in very long-standing cases, someone might have just changed the marking on the Heidelberg system, so it becomes very difficult. So this patient actually went on to have another PDT therapy. And this time round, they performed a OCT angiography on the Heidelberg system, and they felt that there was suspicion of choroidal neovascularization, so they also performed intravitreal ranibizumab in both eyes. So unsurprisingly, fluid remains, and yep, we now move on to what Professor Adrian suggested. We did a ERG for the patient, and the EOG does suggest that there was no light rise, and it was in keeping with a Best trophinopathy. So at this point in time, I came back from my fellowship and I was referred the patient. So we did a gene testing for the patient. So this is the gene testing result. The patient was compound heterozygous for pathogenic mutations in the BES1 gene. Interestingly, in the initial INVITE report, it was suggested that both of these alleles were autosomal recessive BES alleles, and they were not reported in also autosomal dominant disease. Yeah, so I was curious, so I brought the patient's parents in for examination when they came over to Singapore for a holiday. So this is the father. Yeah, the father had vitelliform lesions underneath the retina, even though he never had any eye complaints in his life. Apparently, he had cataract surgeries done in both eyes, but he wasn't told there were any abnormalities, so he couldn't report that. The daughter or the patient couldn't report it to me at that point in time. The mother was normal clinically. So this was the patient with the compound heterozygous. We tested the parents. Each of them had one of the allele. Father, interestingly, was phenotypically presenting with the vitelliform lesion, even though in the initial INVITE report, it stated that this was supposed to be an autosomal recessive allele. Then we also brought in the patient's 4 daughters for testing and examination. One of the each of them carried one of the alleles from the mother. The interesting thing is the 59, the 59T2C allele is in the second daughter, and I also examined the second daughter. She was not manifesting any phenotypically presentation of Best disease. So it's still interesting. I'm still monitoring the daughter at 2 yearly intervals. So if there's any update, it will be quite nice to report this case later on.
How do you account for the father manifesting disease with a recessive allele?
So it's not been reported in dominant disease before, but since then, if I look into the OMIM genetic database, they have now said that at least one case has been reported with one allele manifesting disease. So I'm not sure whether it is an allele that causes both dominant disease as well as recessive disease, but I think more information needs to be gathered.
I would be interested in an EOG for the second daughter. Yes.
This shows the importance of following up because the EOG might be classified as only recessive at some point in time, or something might even be considered as a VUS, so not significant. But then years later, if you have a genetic counselor, you can look it up for you. The classification might change based on the literature that's available. And the second thing is, I wonder if there's also the effect of modifying genes. So that might be recessive, right? But then when you have got a modifying gene, which is not one of those present, it can change the manifestation, the clinical phenotype.
Yes,
we have old photos of the proband way before, since she has seen many ophthalmologists for decades. The initial pictures are going to be very instructive, right? Yes. Because what is the phenotype for her? Does she look anything like her father, the asymptomatic? Yeah.
So unfortunately, I don't think we have any old photos for her. And I fully agree with what Dr. Chan mentioned. Initially, when we first tested the proband, when the alleles came back, one was classified as a VUS and the other one was likely pathogenic. When we sent in the parents as well as the kids, then the allele actually got upgraded into likely pathogenic.
I also wonder whether you could look at the proband's father's siblings. I mean, that might also be interesting.
Yeah. The family stays in Malaysia, so it's pretty difficult for us to bring them
on. I must congratulate you firstly that you were able to build quite a nice family tree here. Yeah. It's not easy in Southeast Asia. I don't know about Korea, but certainly there is a great reluctance for people to talk about inherited disease or whatever social stigma it might have.
Yeah, I think it's also testing is difficult because it's expensive, and for most of this, we don't have a treatment at the moment. So when we explain it to our patients, it's really difficult to get the buy-in for them to spend the money to do the testing. Yeah. So, but we're lucky we had a research grant to actually pay for the testing. So we are able to get more buy-in from patients for testing.
In the second treatment, which is the combination of PDT plus ranibizumab, could you document any change in the choroidal neovascularization with that?
So I personally am not a fan of OCT angiography on Heidelberg. I had a look at the scans. I didn't feel that they were exactly telling of a choroidal neovascularization. So yeah.
Okay. So
not convincing. So yeah, I just end off the talk with a little bit about Best trophinopathies. So it's associated with the BEST1 gene, encodes for a membrane protein for transport of materials across the membrane, regulator of intracellular calcium signaling, and also has got effect on the phagocytosis of the photoreceptor outer segments. I had a paper we talked about there's maybe a possible role in the ocular development because some of the phenotypes of BEST1 mutations affect the axial length, as well as the anterior segment makeup of the patients as well. So might have some developmental influence. So there are multiple distinct phenotypes that has been described. I think most of us will be very familiar with BEST disease. However, autosomal recessive BEST is quite classically have been described in a lot of case reports that they mimic central serous chororetinopathy as in this case. So importantly, there is very marked variable penetrance as well as expressivity, especially in the even in one family, like what we can see in this case example. So in summary, just to have a high index of suspicion, look for atypical features of the disease, and I think in this day and age, even though gene therapy might be quite expensive, I think electroretinogram or EOG is actually quite affordable and easily accessible. So make use of that, and finally, gene test patients who are suspicious. Thanks.
Everyone feel like a mimicker, and maybe the case, my case too. So I would like to show you the case. Thank you to invite me today. show you the mystery case. I will show you the benefit of the imaging ecosystem from the diagnosis treatment decision in this multimodal imaging era. This financial disclosure. So we're talking about the clinical case of the 61 years woman. She came with a central vision blockage for 1 month. She has the history of the chronic CSC before 4 years ago, and completely just only focal laser, completely recovery. This is the day that she came to me. This session, she had shallow subretinal fluid with the double sign, and she's quite old than before, and interesting history of the chronic CSC. Due to we have just only one platform of the imaging, so we trace back at the last time 4 years ago. She had this problem with diagnosis of the CSC. But when you closing look on this one, beneath the RPE, last time is like a hypo-reflective signal, but today she had the hyper-reflective signal. At this time, we had like a tech adoption OCTA, so no doubt that we can use the OCTA to diagnosis this patient and take a look. Due to I use the OCTA on that slab, and I see the signal of the CNV. I'm not sure that this is the active CNV or quiescent CNV. So I think so. We see the main trunk and also the like, maybe we call it active or not. And so at that time, I'm not sure that how people think now. So at that time, I come with the diagnosis of secondary CNV, PNV. So I do the injection. After the injection, normally in Thailand, we can provide the bevacizumab in every patient. So I will start with the bevacizumab, and I schedule for 3 injections. Normally I do when we do with the forum, and this come with the 3 session compare. Firstly, I will take a look on the thickness map, and just at the first glance, we can see the yellow center popping up, and also obviously this case for the cross section, it seems to be not working. Might be non-responder with the CNV. So at that time, I tried to switch the medicine, which is I thought it might be more potent or another choice. After first injection, at 1 glance again, we see it look like it's improved a little bit. So we do another injection. After another injection, it's come like this. So why it doesn't work for like 5 injections already? Now I have to rethink. They think again and take a look. This is the first time, and this is the second time that we do the OCTA. I'm not sure that it's changed or not, but if we take a look, it's quite a little bit changed from the periphery of the lesion. The CNV is look like I'm not sure that it can call the pruning or not. But due to I'm not familiar with the OCTA, so I call my old friends the dye injection. But just take a look here. Normally, when I use the forum, the retinal workplace, I can have the to compare from the past and present. With this, I choose the RPE fit, and a little bit we can move the segmentation to get the well-needed aid of the CNV. I usually do the 6x6 to scan, but I don't think it's easily to do the progression is regressed or not. So when I scanning with the 6x6 and have some signal, I will do the 3x3 for follow-up. For this case, I use the fluorescein, and I think I see something. This is look like a small two smokestack area, and I did also come with the diagnosis. Maybe it's chronic and CSC and dormant and crescent CNV at that time. I also do the ICG. This is ICG on the Heidelberg. So I just wait for the class to have the ICG. The ICG of the Heidelberg, I think I see the faint hypercyanation plaque. So maybe the simultaneous CSC with the CNV or the chronic CSC with the dormant CNV. But we do all the things that I have the injection already for 5 consecutive injections. So now I try to have the laser. I do the laser treatment over that 2 smokestack, and this is the result. So I think that when we do the cross section, I take a look of the cross section. It's quite good, but in the OCTA, the thickness map, it's kind of like a sunset gravitation down. So I thought that it might be the turbid fluid, and it's shut down already, and it's gradually settled down there. This is when we have the retinal workplace. I can mark what we did last time, and we can see clinical progression easily. And also when we combine of the OCTA with the thickness map, if we see on the left side at first, we just thought that it might be the fluid from the CNV, because the CNV is at the center of the fluid. But on the follow-up, and we know that this case already we did the laser, so this might be the regression. And if you see that, I thought if I see this in the first time on the left, that it is the present. If it is the presentation, maybe we thought just think about is it actually CNV originate of the fluid or not, because the CNV is at the side of the main fluid. So this case, I think we can go see bye-bye with the fluid, but it's really not. It's not the end. So after the fluid is gone, we call the PNV, and the PNV count. I think this when we follow up, we see the fluid that of accumulation is going down, but after we review the center of the slab, we see some amount of the fluid is quite a little bit bigger. So I'm not sure that CNV come back or the CSC, but at that time I did not have any angiogram available, so I tried to have another injection. This injection, we thought that at first we do the bevacizumab, ranibizumab, and now called aflibercept. So after we did the injection, I follow up the patient for 2 weeks to see the response. That original thought, I think if it is CSC, it might not work, and the fluid will be more or stable. But after injection, I appreciate that, okay, 2 weeks and it's gone. So it might be active PNV, something. We also, this is the, and in the square, it's the same day after we do the follow-up, the all fluid gone at the center, and also I score down a little bit, and I don't see any subretinal fluid. So I decide to have the continuous injection. But after 3 injections, it's come back again. So I continue to have every 4 weeks interval without angiogram because it's not available at that time. So I do 3 injections, 8 injections. But after we tired, the patient tired, she said, at the center, I feel fine. So I decide to not inject anymore. Yeah, so I agree. So at that time, the fluid is quite a little bit down off the center, and the center of the vision, she is fine. Even she has a little bit of the shallow subretinal fluid, I relax, maybe just on the side of the, okay, just shallow subretinal fluid, we don't have to treat. So just monitor. This is after we monitor for a while, maybe a lot, quite long, 1.5 months, 1.5 years, 18 months. Gradually follow up, and you can see the after injection, we stop the injection but still follow the patient. This time I see the fluid, and I think you also think that fluid is like quite round and not originally from the point of the CNV that originate. So I just think it might be okay control of the PNV or another CSC come. But it's off the center, so we don't do anything. We follow up at like 18 months, and after that, she can with this again. So now, when I take a look, I don't know what to do at that time. So we did the all like anti-VEGF, and also I think that might be another session of the CSC, but due to that, I don't have the angiogram, but I do the PDT on the OCT. I plot the OCT on the OCTA last time, and the shallow FIPD. So I did it at that point, and I did the PDT. And after the PDT, it's gone. I'm not sure with the effect of the PDT or anti-VEGF, but just one time and it's done. After that, it's come back again in some time. But this time you can see the elevation of RPE. It's not look like the same. It's a little bit heaving up, and we do the evidence of the angiogram. And also at this time, I think it is an active CNV. I did bevacizumab in the first time, but it seems it doesn't work. I switched to aflibercept for 3 times. And this is the thing that we have to continue for this patient. I don't know what's going on at this time. So I present the case of the pachycolloid, present with maybe combined CSC, PNV, or is switching, and also in the future, maybe develop the PCV sometime. I show you the integration of the multimodal imaging. You can see along with the clinical response, if you have the forum, clinical workplace, retinal workplace, you can mark everything. Multimodal treatment might contribute to the improvement of the patient. Thank you.
This looks like a Netflix drama series. All to be continued, series 1 and 2. What was your original diagnosis? I mean, if you look at the ICG again, are you convinced that this is pachychoroid neovasculopathy, or is this something else?
I'm not really sure, because the choroid, I don't think it have the thickening of some pachy vessel, but I don't think it's so thick.
Anna?
I think the initial angiogram, where the leakage was at the bottom, it do look like choroid neovasculopathy. I mean, even though there wasn't a lot of hyperpermeable leakage on the ICG, and that there was like a plaque that you could see on the original, there. I mean, there is some pachy vessels in the early phase. So I would go with the PNV diagnosis in this case. And obviously, we know that the response to anti-VEGF is always not so straightforward. It is it has a because it has 2 components of not just the neovascularization and the leakage, but also the hyperpermeability. So I think that's the combination therapy is usually the best thing.
I think 2 points I want to bring up. One is, of course, determining true non-response. I mean, very often we are too quick to label a patient non-responder. what you did in the second round was correct. You bring the patient back after 2 weeks and then at 4 weeks. Because even if the anti-VEGF agent you used was not the appropriate one, you would see a reduction in fluid with PNV. I mean, it is a type of choroidal neovascularization, just with a thick choroid, right? So you would have expected to see at least some minimal response, not complete, after 2 weeks at least. Right? So rather than label them the disappointment, the problem now is when we're giving 3 injections, some people don't even see them in the intervening 3 months, and you only see them after the 3rd loading dose, which I think is not helpful. You really want to be able to assess them at each point. And if you have a true non-responder, like this case where you're giving injections and the fluid is still increasing, then of course, I mean, the classical teaching is go back, rethink, and you did that, fluorescein angiogram, and sometimes you'll see micropolyps. May not be the obvious PCV. And if it's polypoidal, then you need to treat that accordingly. Do you think that the response to PDT was better than focal laser?
I think due to this case, I think this is like a pachychoroid.
Yeah.
So the PDT might work well. In the originally, if you do the focal laser, if still have the pachychoroid in the future, it might come back. So I decided to do the PDT at that time.
Absolutely. So I think, this is quite an important point also. When you do ICG, you want to wait for as long as possible to capture the area of hyperfluorescence on ICG. So if you stop at 5 minutes or 10 minutes, you won't be able to properly zone it. Right? But if you have a 15, 20, or 25-minute study, you'll be able to then see late staining of the choroid. And that's where you would apply the PDT. And it's very important where you apply the PDT as well. If you see micropolyps, for example, you will see them early, but you will see late staining and late leakage. So the art of PDT is being lost. I mean, I think fewer and fewer people are using PDT, but sometimes it's really indispensable. For a case like this, from a main Netflix series to a mini series, you really want them to have a much shorter course of action. What about the fellow eye? I'm interested to know about the fellow eye.
The fellow eye is really good.
Okay.
Everything, not really big.
Okay. So that's also unusual. Normally we see pachychoroid in both eyes. Right?
Yeah.
We'll leave that for another day's discussion on why you get pachychoroid in both eyes. But very fascinating case. Any other learning points from the audience?
I just want to know that if there is someone to have rethink at this time. I mean, we have many kind of the anti-VEGF. So do we would like to switch first or just doing the dye injection in the case like this first?
In my own experience, I think if you've got a non-responder to, let's say, bevacizumab, it's worthwhile trying something else. We know that the effect on the choroid varies between the anti-VEGF agents. In fact, Eylea was much better than ranibizumab in the early days. Right? So we know that there is selective and variable response of the choroid thickness. So when you give aflibercept, you get a better response. Now we are seeing that with faricimab, you get a reasonable response, but the best response is brolucizumab. Okay? So when you want to have an effect on thinning choroid, brolucizumab is the best, but it comes with the risk of IOI and so on. And in this case, maybe a brolucizumab would have worked without laser. What's your experience with brolucizumab in Thailand?
Brolucizumab, I think it's quite very work well in the. I usually selected in the if I select for the first time, I select in the big PD.
Yes.
Yeah.
It worked very well.
Yeah, it's worked very well in the big PD.
But it's a bit of a Russian roulette. You don't know when the ball will stop and where. Yeah. What about your experience? And anyone else experience with brolucizumab in Korea? Yeah. When do you use it? When do you use it?
So I'm not using the brolucizumab as a first choice.
Yeah.
I'm using that as a thoracic treatment for refractory cases.
Yeah.
This might practice.
Yeah.
The same with you.
Yeah. But I mean, it's a useful tool to have. In Singapore, it's not approved. So we have to send patients to Thailand, Malaysia.
But an interesting thing is, in the United States, the AI inflammation issues is kind of very severe, right?
Yeah.
But in Korea, although more and more physicians are using brolucizumab because we now think that inflammation is not really an issue in the Asian countries. I don't know why, but
I think the occlusive vasculitis may not be so common, but IOI is more common in Asians. If you look at the Hawk and Harrier, the Japanese cohort had the highest rates of IOI, more than 4%. And that was actually the first clue that brolucizumab was going to cause significant IOI. So I think it's still a major problem. It's really whether you pick it up early and whether you have screened your patients well beforehand, right? So those who have existing very, maybe asymptomatic retinal vasculitis, be very careful with those because they will flare up in your face. So unfortunately, we don't do wide field, angio for all these patients. But I think still the vigilance is very important for brolucizumab.
The ones who use brolucizumab in, do you do it with prophylactic steroids or?
No.
No.
But I agree for the IOI. I think so for the incidence of the IOI is much more than 4%.
Yeah, IOI itself I think is more.
Yeah, and I also, but my experience that I think the brolucizumab is quite good due to the long action. I have the patient who had the IOI with the periphery vasculitis, and I did OCTA injection.
Oh,
not after, not OCTA, TA, IVTA. So but after just only one injection with very long chronic history of anti-VEGF, just only one injection and it's done, and it's quiet for the treatment for like 5 months. Yeah. After I do the IVTA for 3 months, the inflammation come back. At that time, I thought, oh, how long I have to treat this patient with the steroid. So I repeat the IVTA. At that time, the CNV is still quiet. But after another 2 months, the CNV still come back, the leaking come back. So I think for like duration is quite long inside the eye.
So there's certainly a place for brolucizumab. I mean, I've seen cases where it's not responded even to faricimab or aflibercept 8 mg and responding to brolucizumab. Okay, I think we'll end here, but thank you very much to all speakers. We had interesting discussion, interesting cases. I hope you have enjoyed the session. Thank you very much.